So this will be a quiz and you can type in your answers on some of the questions. Just a quick start, a pacemaker is essentially a device that produces an electrical stimuli and that causes cardiac contraction. And it's used when the intrinsic cardiac electrical activity is inappropriately slow or absent. Now how does it function? Typically by sensing the intrinsic cardiac potential. If that intrinsic cardiac potential is not there, then the pacemaker will release a little electric stimulus which will cause a cardiac contraction. Now this electric cardiac pacing was actually first described in 1952, so about 60 years ago, and the permanent transvenous pacing device was first introduced in the early 1960s and transesophageal pacing in the 1970s. But interestingly, even though it's been around for that long, I think still for us PD cardiologists, when we start off, it is a little confusing in terms of the terminology. So the first question, what are the pacemaker components? Can you name the 3 components of a pacemaker? Here's a pacemaker, so just name what are the 3 components. So you see here where it's written St. Jude's, right? That is your pulse generator. So that is what produces your pulse. Then you have to have your whole electronic circuitry, right, which is connected to the lead system. So you've got in any pacemaker, you have a pulse generator inside it, and then you've got electronic circuitry which connects it to a certain lead system. And that lead system, and you can see down here, the end of the lead is what is attached to the myocardium. Okay. Now, in a pulse generator, you've got a battery, right? So what is the current standard battery? What is that battery made of? And the current standard battery, anyone, what is it made of? Which type of batteries do we use right now in the pulse generator? Okay, so it's really a lithium iodine cell, and it does have certain advantages. It's got a long life, 4 to 10 years, and the output voltage, so the output of this pacemaker, of this battery decreases gradually with time. So it's not like, you know, the battery is working today and the battery fails tomorrow. Sudden battery failure is very unlikely. The output decreases very gradually with time. And so these are the 2 major advantages, that it's got a long life and you're not going to have sudden battery failure. You're going to have time because the pacemaker is gradually going to start malfunctioning. Okay, and this is an example of a transvenous lead placed. You've got your pacemaker. You can see inside it you've got the pulse generator and then the electronic system, which is then connected to the leads which have gone through the subclavian, SCC, and into the right atrium. So transvenous placement of a pacemaker. Now next question is, what is uni versus bipolar? When we talk about a unipolar pacemaker versus a bipolar, what do we mean? What do we mean by unipolar? What do we mean by bipolar? Okay, so within the heart would be which one? So you mean bipolar in that. So in a unipolar, you've got a single negative electrode and that is in contact with the heart, right? You can see here in the yellow line. And then this circuit gets completed by placing an indifferent electrode somewhere else in the body, right? And you're right, in a bipolar, both the electrodes are in contact with the heart and the circuit is completed across a small field. So you've got both the cathode and anode, the positive and negative, both the electrodes are in contact with the heart in a bipolar. So in a bipolar lead, your chance of, for instance, pacing something else may be quite limited, like diaphragmatic pacing and so on. Okay, so now this is an example of a dual chamber. You've got the pacemaker here, generator in the left pocket, then you've gone through the subclavian vein, superior vena cava. You've got one of the leads in the right atrium and one in the right ventricle. Now these are pacemaker leads. You can see here that you've got the pacemaker leads which are attached to the wall of either the atria or the ventricle. Now these pacemaker leads, can you name the methods of fixation? These are the three methods I have here. Can you name what is the first, what is the second, and what is the third? And this is, oops, I gave you the answers, so I'm taking them out. So what are the three methods of fixation that you can see in this slide? So when you take your pacemaker lead in, okay, so the third one is screw in, right? You can see the screw, and that means when you take that lead, you screw it into the myocardium, okay. What is the first and second? Do you know any other methods of fixation? Okay. You've heard of sign also. So you've got something, the first one, the third one, which is the screw in lead, is an active fixation. That means you have to screw it into the myocardium. The first two are both passive fixation. Okay, passive fixation means you just take it and you touch it against your myocardium. You're not going to screw it in, you just push it in. So it's passively fixed against the wall. Problem with it is it can dislodge. What is the problem with the screw in lead? Is you're screwing it in, so you have chances of perforation and so on if you're not careful. Problem with passive is you're just pushing it against the wall and hoping it gets stuck in some trabeculae. So there is a chance of dislodgement or the pacemaker not capturing. Now the first one, if you see here, is called a tined tip. So it's rectangular and it just goes and you push it into the myocardium. The second one is more angled like this. It's called the finned tip. So these are both passive fixation. So if you ask methods of fixation, you can really say passive and active. Active being the screw in lead. Passive, you have different tips. They can be the tined tip or the finned tip. Okay, all clear on that. Now this is how you put your pulse generator in, right? Either subcutaneously or submuscularly, and you connect it up to the leads. Now when you connect it to the leads through the veins, like you saw in the previous pictures, that's your transvenous approach. But many times you do epicardial leads, where you put it surgically onto the heart surface. Now in which conditions you use epicardial leads? Where you're not going through the veins, but you're just taking the leads and putting them on the heart surface. Where do you use epicardial leads? Okay, so you could use it in the post-op situation because you may need it only for a short period of time. And anyway, so when you're coming out of the OR, you put epicardial leads connected to your temporary pacing. When the patient doesn't need it anymore, you disconnect it. Where else do you use epicardial leads? Anyone else? Okay, after ICR. So after any post-op conditions, you could use, but more commonly, okay, let us say it was a congenital AV block. In which age group would you use an epicardial lead? So it's typically used in children, right? Because in smaller, especially in smaller children, because if you put an implanted endocardial lead, it eventually becomes too short, right, as the child grows. And so you need to rechange the whole system. And therefore, in neonates and infants, some people say less than 2, less than 5, but definitely in smaller children, you use epicardial leads rather than transvenous. Okay, so children and yes, in the post-operative situation. Now we'll move on to the basics of pacemaker terminology. So what is the rate of a pacemaker? It's the heart rate at which the pacemaker will pace. So if you set the rate at 80, it will pace at 80. You set it at 90, it will pace at 90. What is the standby rate? What is a standby rate? Okay, this may be a little new one for everyone, so I will just put you that. But the standby rate is the lowest rate at which the pacemaker will pace. So for instance, in some pacemakers, you set them at you have a rate responsive mode. That means when they need it, the rate goes up. So the upper limit could be 80, it could be 90, it could be 100. But the lowest rate at which the pacemaker will pace is your standby rate. So if you set your standby rate at, let us say, 40, that means that pacemaker lowest rate it can pace is 40. It's never going to pace at 30. It may pace higher than that, but the lowest it will go to is that. Okay, that is the standby rate. Now, what is capture? What do you mean by capture? Stimulus causing contraction. Okay. So capture is when you give an electrical stimulus and you are able to have a resultant contraction. That's right. So yes, if the question is it stimulus causing contraction or is it stimulus causing depolarization, right? So it really is, when you talk about capture, you mean that there is depolarization and a resultant contraction of the myocardium. So both have to really occur in response to that electrical stimulus. So just saying a stimulus causing depolarization is probably not enough. A stimulus causing depolarization with resultant contraction of the myocardium is capture. Okay, now you can see in this ECG here, you have a P wave, you have a pacing spike, and then you have got a QRS. So what is getting captured in this ECG? Atria or ventricle? Both atria and ventricle. Let's see now. When you have the pacing spike, you're capturing the ventricle. So there's definitely ventricular capture, right? So there's ventricular capture. That's right. Now, if you see in the last 3 weeks, right? You've got not the last week, but just before that, you've got a pacing spike, but you're not getting a P wave after that. So actually, it's not capturing the atria. So there's a sinus rhythm. There's a P. It's sensing that, and then it's letting a pacing spike out, and you're capturing the ventricle, right? So that is what we mean by capture. Now we'll move on to sensing. What is sensing? So what is your definition of sensing? What do you mean by sensing? And what is sensitivity? It's kind of good to think of the definitions because that forces you to think of what the concept is. And is 8 millivolts more sensitive than 2 or less sensitive than 2? So able to identify the native electrical activity is sensing. Okay, and what is sensitivity? Okay, and that's right. That is actually, it is not the ability to identify necessarily the contraction. It's the ability to recognize the native electrical signals. There may or may not be a contraction, that depends on the myocardium, right? And sensitivity is that minimum intracardiac signal which is required by the pacemaker to sense it and then initiate some kind of pacemaker response. That pacemaker response may be to get inhibited or to pace or to whatever. So the minimum intracardiac signaling which is required by the pacemaker to initiate some kind of response is your sensitivity. So is 8 more sensitive or less sensitive than 2? 8 millivolts is less sensitive. All agree with that? Yes. So 2 millivolts is the most sensitive. 1 millivolt is even more sensitive, and we'll go over why. Right? So if you see here, right, you've got, this is your electrogram. Okay, one is 3 millivolts, one is 10 millivolts, right? When you have a sensitivity of 2 millivolts, both of these have enough amplitude that they can be sensed. But when you have a setting of 8 millivolts up here, only the larger amplitude signal is going to be sensed, right? So you're not going to be able to sense the amplitude that was 2 millivolts. So therefore it is less sensitive. So the lower the number, the higher is the sensitivity, and vice versa. So all clear on this? So we'll move to the next concept, which is threshold. So what is threshold? What is threshold? Okay, so it's the minimum energy to be given, no, to induce depolarization, or to do what? So it's the minimum quantity, right, of either, yes, it could be minimum voltage, or it could be pulse duration, or it could be charge, or it could be energy. But it's the minimum quantity of output produced by the pacemaker that persistently produces an action potential as well as myocardial contraction. Okay, so it's not just depolarization. Again, that threshold has got to also produce, that output has got to produce a myocardial contraction. And is a threshold of 8 better than 2? No, it means that you need higher energy to capture the myocardium. Right, so it's the minimum. It could be, you see, when we talk about threshold, you could set threshold in terms of voltage or in terms of microjoules or pulse duration. It could be in terms of anything. But it's the minimum. The easiest for you is to say minimum voltage that persistently produces an action potential and myocardial contraction. So in threshold, you definitely do have to contract. In sensing, you're actually sensing native electric potential. In threshold, you need to produce a myocardial contraction. Okay. So what is the output and sensitivity set at? Let's say you find that your threshold is X and your sensitivity is X. What do you typically set your output at? What do you typically set your sensitivity at? Okay. So you can go 1.5 to 3 times the pacing threshold is identified. If a patient is very pacemaker sensitive, you may want to go 3 times. You don't want to run the risk of not capturing. If he is, even if his heart rate goes down, he doesn't become symptomatic, you can just set his pacing threshold a little lower. So output would be 1.5 to 3 times pacing threshold identified, and sensitivity. Sensitivity would be how much? The sensitivity would be half the sensitivity threshold value. Well, see, now that's the thing, right? If your sensitivity was 4, right, then you want to do what? You want to make it little more sensitive, right? So you're going to set it at 2. So at half of that sensitivity value, whatever you get, so that is even more sensitive, because you don't want to run the risk as there are changes in the pacemaker that you're not able to sense. Okay, now this is a temporary cardiac pacemaker that a lot of you will have in your unit. You can see down here is the rate. Okay, the upper right button is the output. It can go up to about 12 volts, millivolts. This is your sensitivity here, 1, 1.5. If you set it at 1, it's very sensitive. And you can either put it in demand mode, that means as needed, or asynchronous, which means it continuously keeps pacing away, right? And then this is typically connected to your epicardial lead. Now we need to so you've got this in, you want to test your threshold and your capture and your sensitivity, right? So how do you do it? So this is going to be in a quiz format. Now, if the patient is being paced more than 90% of the time, it's a little dangerous to be testing capture and doing all this. So you can do this more in a stable patient who is not that pacemaker dependent. So when you want to test capture, you turn the pacemaker rate to what of the patient's intrinsic rate. So say his intrinsic rate is 80. What do? You set it more than the intrinsic rate or less? Okay. So you're going to put it about 10 beats per minute higher. So if his rate was 80, you're going to put it at 90. Then what are you going to do? To the milliamperage, you're going to do something to it until you stop capturing. So what are you going to do to your voltage, to your output? Reduce or increase? So you're first going to, so what you're doing now is you are pacing the ventricle, right, at a higher rate than his own rate. You keep decreasing the milliamperage, you keep decreasing your volt until you don't see your pacing spike anymore. There's no capture, right? So that means at this point now you're not capturing at all. So let us say you set it at 10, you come down 8, 6, 4, and now you don't capture. Then you slowly again, what do? Then you slowly again increase it until you get a depolarization after every pacing spike, right? And you get on your ECG, you now at this point, after every pacing spike, you're seeing depolarization. So that voltage at which depolarization is occurring with every spike, that voltage, that milliamperage is your what? That is your threshold, right? And now you're going to set the milliamperage to what we discussed, which is 1.5 to 3 times the determined threshold. Is everyone clear with this? So you first go about 10 times higher than the patient's intrinsic rate. You put your output on maximum. So now you're going to go on capturing his myocardium. Then you decrease your output, decrease your output until you see no pacing spike at all and no depolarization after that. Then slowly increase it until you get pacing spike and depolarization. That point is your threshold. Then you set your milliamperage 1.5 to 3 times the threshold. Okay? All clear on that? Now similarly, sensitivity. What do you do? How do you test sensitivity? What do you set the heart rate at compared to patient's intrinsic rate? More or less? So what are you trying to do in sensitivity? Right? You are trying to see if the pacemaker can sense that patient's rate. Right? First thing he's got to sense is the patient's rate. Then he has to decide, okay, this rate is too low, I'm going to pace, or this rate is too good, I'm not going to do anything. So when you are testing sensitivity, you have to see his rate. Patient's heart rate is 80. Now you set the pacemaker at 70. Because if you're going to set it higher, right, than his own, if you're setting the rate of your pacemaker higher, there's nothing to sense, right? He's going to keep pacing. So you set the heart rate 10 beats lower than the patient's intrinsic rate. Then you put the output very low because now you don't want it to keep going on pacing. You put your output at the minimum. Say your threshold was 2, you put it at 2. Then what do you do to your millivoltage? You increase it or you decrease it, your sensitivity? Do you make it come down to 1 or do you increase it? So what do? You keep increasing from 2 to 3 to 4 till the sense indicator stops flashing. That means on that pacemaker, and let's just quickly go back. Oops, I'll have to do all this. Go back to this. You see here, sense. Let me. Do you all have the same pacemaker? You see here. You see this. This is sense. You see here. This is pace. You go tomorrow morning and look at your pacemaker. When the pacemaker is sensing, it will keep blinking on that sense. When it's pacing, it will keep blinking on the pace, right? So what you are essentially doing when you're doing this is, when you want to test your sensitivity, you are going to go on, you put your heart rate lower, right? You put your output minimum, and you're going to go on increasing from 1 to 2 to 3 to 4 until it stops sensing and the pacemaker indicator starts flashing. See, you have set the patient's heart rate is 80. You set your pacemaker at 70. That means your pacemaker, if it is sensing the patient's heart rate, should your pacemaker ever go off? Your pacemaker should not go off, right? But when you change the sensitivity so it's so sensitive, so not at all sensitive, now you've made your pace sensitivity 8, it's not sensing the patient's own rhythm. It will start pacing at 70, right? So when you start seeing that it's pacing and the sense indicator is not sensing, that means that you are not sensing anymore. From this point, you again decrease the millivoltage until the point where the sense indicator starts flashing. So that value is your sensing threshold. Now, once you have that sensing threshold, which is the low value at which you're able to start sensing, once you know, okay, my sensing threshold is 4, you will set the millivoltage at half of that sensitivity value. Is that clear to everyone? And then, depending on the rate you've described, you will reset the pacemaker. Okay? I hope that's clear. So now if you look at this pacemaker here, this is another type of the temporary one that you have. You have got an atrial output, right? You have, which is going to be your threshold. You have an atrial sensing. You've got a ventricular output and a ventricular sensing. And you're going to set your rate. You may, if you're doing a DDD pacemaker, you may even set your AV delay, right? So when you're doing it through this, you can look on your monitor, and you can also see here, it should flash for you whether it's sensing or not. But you can look on your monitor and see whether, if you set the rate at 70 and you go on increasing your sensitivity and now it's pacing at 70, you know at that point that you're not sensing anymore. Okay, all clear? So we'll move to this, which is what are the modes of a pacemaker. Do you know what we mean by when we say modes of a pacemaker? Right, okay, DDD, but what do you mean by mode? What are the two basic modes? Right, so DVI, VVI, these are all modes. But what do you mean? What are the basic modes of a pacemaker? You can either have, it means you can have, it indicates what are the pacemaker capabilities, right? So it's either a fixed rate or a demand. So fixed rate means that the pacemaker will fire at a specific rate regardless of the patient's own rate. Right? And this is what will determine for you VVI, DDD, right? Whether you want rate responsiveness, whether you want fixed rate. If you want a pacemaker to fire at just at some rate, what kind of mode will you set it in? You're not going to have sensing then, right? You're going to have a VOO mode. You're just going to keep pacing. So yes, your sensing and pacing are part of your mode, but essentially your mode indicates what is your pacemaker capabilities in there. And when you say it's a fixed rate, you don't need any sensing. So it just fires at a specific preset rate. What is a demand mode? It paces only when the patient's heart rate falls below a preset level, right? Now in a demand mode, do you need to sense or not sense? Should the pacemaker be able to sense in a demand mode? Yes or no? In a demand mode, should the pacemaker be able to sense? And the answer is yes, right? If it doesn't sense, it's going to keep pacing, right? So it has to be able to sense. So these are essentially the two modes that you need to determine. Do I want a demand? Do I want a fixed rate? And that will determine where you pace, where you sense, and so on. So another concept that you need to know is hysteresis. So anyone, hysteresis? What is hysteresis? No, hysteresis. Okay, this is a little, it's a concept that I think you have to keep revising. But basically, it's the maximum interval from the intrinsic beat. What is the intrinsic beat? From the add-on if the RR interval. Right. So if your intrinsic beat is the patient's own beat, right? So when you take the patient's own beat to the next paced beat, that interval will be longer than the paced rate, right? So say the paced rate is here to here, right? You can put a hysteresis that when he gets his own intrinsic beat, the pacemaker will come later. So you're right, it is an add-on. So if say his pace rate is set at 80, now he gets an intrinsic beat, his own beat comes. Then instead of giving him a paced rate at 80, you wait a little bit and give him the paced rate. So what is the advantage of hysteresis? Why are you trying to do this? Why are you saying if he gets his own intrinsic beat, I will wait a little bit before I pace him? What is the whole point of that? So you are allowing the maximum possible time. You're giving the myocardium a chance to beat again. So what you're essentially allowing is recovery. Because let's say the myocardium is trying to now produce its own beat. And every time it's trying, the pacemaker is inhibiting it by firing at its own time. So what you do in hysteresis is you're allowing the lowest possible rate after intrinsic beat. You're telling the myocardium, I'm giving you a chance, beat again. If it doesn't beat, now let us say you set your pacemaker rate at 80. By 90 beats, the heart rate of 90, still nothing has happened, yes, your pacemaker will come in and give a pacing spike. So you can set the hysteresis and anything. You could say, hey, if he gets his own beat, I'm going to wait for 3 milliseconds. I'm going to give him a heart rate of 100, let it be. But I'd rather have his own intrinsic beat. So hysteresis can be set by the operator. So when we talk about the hysteresis interval, should it be greater or lower than the lowest rate interval? As long as it doesn't result in symptoms, right? Because whatever you do, it shouldn't result in symptoms, right? So the hysteresis interval will be greater than the lowest rate interval that you set on that pacemaker. But you should make sure that it's not that you're letting him have a stroke serum while you wait for his myocardium to recover. Okay, now what is AV delay? I think this is quite, we're all familiar with. AV delay would be equal to our PR interval. And now this is really described for PR interval, and really described for dual chamber pacemakers. It would be equivalent to a native PR interval, and it's your time between the atrial event, whether you pace the atria or you sense the atria, and then whenever you get your ventricular event. Okay, and it gives that pacemaker to decide whether or not, okay, now there was a P wave, is this ventricle going to produce its own QRS, or do I need to pace it? So sometimes we give the AV interval, we set it a little longer than your normal PR interval, again giving the myocardium a little time to see whether it senses that atria and does its own ventricular beat. Okay, and you need an AV interval set in your pacemaker to allow the ventricle time to fill, because obviously the atria contracts and there's no time before the ventricle contracts, you don't have diastolic filling. Okay. Similarly, VA interval is the opposite, the time between a ventricular event and a paced atrial event. So when you pace the ventricle, you give it some time before again you restart your atrial contraction and so on again. Now, what is a fusion beat? When we talk about in pacemakers, what is a fusion beat? And It's not exactly sensing and pacing simultaneously. See, it's really the combination of an intrinsic beat and a paced beat. So what happens? You've got your own intrinsic. The myocardium is producing its own beat. Same time, a paced beat is coming, and that really is a fusion beat. When you have so you may get, for instance, you have a QRS that's come, but also a pacing spike. So at the same time, they're both coming, and that is a fusion beat. And that means that maybe his own intrinsic rate is coming. So maybe you have to reduce your pacing rate so that his own intrinsic activity can come up. So when you start seeing fusion beats, it means your own intrinsic rhythm is coming up. Turn down the pacemaker. Okay, and it will look very different. The morphology could look like a wide QRS. It looks like a very abnormal beat. And actually, if you get a fusion beat, you get paced plus intrinsic, so they have very good contraction because it's like getting a double depolarization. Okay. Now we'll just do a couple of these. What is the diagnosis here on this ECG? And I'll tell you that this spike here, see the yellow line, is a pacing spike. Okay, so not loss of pacing. I just told you it's loss. There's a pacing spike, right? Okay, you want to call it loss of pacing? I guess that's okay. It's really loss of failure to capture, right? So we typically say failure to, when we say failure to pace, we mean failure to capture. We've got the pacing spike, but we're not capturing, right? You're not seeing a QRS after this. So can you give 3 reasons when you can get failure to pace or failure to capture? So it's okay. I guess we can use it synonymous. We can use it as the same concept. We're not pacing, we're not capturing. So, okay, lead dislodgement is one. Fracture, displacement, that's right. And you can see here again what is happening here. See this one down here, right? So you're getting again pacing spike, but no ventricular capture. Here, pacing spike, no atrial capture. So you're not capturing it, right? That's right. You're not capturing it at all. So when you get this loss of capture, what do you think of? One, it could be circuit failure. Maybe you're not producing a proper pacing spike. It could be your battery is going, right? Your battery could be depleted. It could be that you're not setting it right. You need more threshold, right? You need more output. Maybe the threshold is higher, so you need a further higher output, right? So maybe your output is not set right. Could be an insulation break, as you said, a fracture. Could be that the lead is dislodged or perforated. Could be that it's not connected properly to the pulse generator. Or it could be something that increases your capture threshold, like metabolic and electrolyte abnormalities, medication, myocardial infarction. So you need to think of all these different causes. So whenever you have a pacing spike with no capture, you start from here. Say, look at the generator, look at the connection, look at the battery life, look at the circuit, get an X-ray, look for dislodgement, look at your electrolytes, look at the medications the patient is on. So you have to do this whole, look at the threshold. You have to interrogate your pacemaker and see, is the threshold become too high because there's scarring or edema around the pacemaker lead? A lot of reasons that can lead to loss of capture, and worth reading this chapter on it. Here, what is happening here? So you see this one is actually there's a P wave there, but there's also a pacing spike, right? You see here on the T there's a pacing spike. You see here after the P there's a pacing spike. So what is happening? So it is, what's wrong with this pacemaker? It is not sensing. Right, that's right, it's not sensing. Because in spite of P wave, you're getting pacing. Look at this lower one. You've got a P, but you're still getting a pacing spike. That means it did not sense the atria. Look here. You've got a QRS and then a T, and then you've got a pacing spike. It did not sense the ventricle. So whenever you get pacing spikes, which are very random, that means there is failure to sense. Okay? So what are the causes of undersensing? When we talked about causes of loss of capture, what are the causes of undersensing when the pacemaker doesn't sense? Couple of causes. Okay, so I think this chapter everyone needs to read. One is improper. Okay, it could be, yes, it could be that the sensitivity is very high and it's just, the pacemaker setting is, you've not set it right. Say sensitivity is 3 and you've set it at 6. So you program the lead sensitivity too high. Could be improper lead position. Could be dislodgement. So a lot of the things are very similar. Could be insulation break. Could be loose connection. So a lot of things that cause failure to capture can also cause undersensing. It could be battery depletion. Whenever you put the magnet on the pacemaker, it stops sensing, right? So all these are reasons for undersensing. Do also remember hyperkalemia. When the potassium is high, it may undersense. What is happening in this case to the atrial lead? Let's see here. The atrial lead. So the atrial lead is actually moved. It's gone into the tricuspid valve. The right atrial lead dislodgement, obviously it's unable to sense that the atria has contracted. Okay, all clear on that? I think I'll end with this. It's now 6:20, and next time we'll do types of pacemakers, indications